and welcome everybody to Rhythm Interventions Online. The session that I will be chairing this afternoon is on a live case of his bundle pacing. I'm joined by an esteemed group of fellow panelists. Dr. Pierre Lambiase is a physician at University College London. Dr. Gaurav Upadhyay from University of Chicago, and Dr. Andrea Russo from Cooper Hospital, all of whom probably need less introduction than myself. I'm Dan Lustgarten from University of Vermont. And what we're going to do is we're going to go live to the Geisinger Clinic where Dr. Pugal Vijayaraman is setting up to do a HIS bundle case. Before we go there, I want to remind the audience to please submit questions. It's okay, whether they're very, very basic or complex. Please feel free to submit anything that's crossing your mind so that we can address them and hopefully shed further light on how one goes about performing HIS bundle pacing and anything relating to the subject. Additionally, at some point as we're going into the case, I'll post on the site a question for people to ponder and answer, and we'll give you a few moments to look it over and submit your choice, and then we'll review people's responses and discuss it. And with that, I think we can go ahead to the Geisinger Clinic and do a little introductory video and get on with the case.
Hi, I'm Pugal Vijayaraman. Hi, Dan, Andrea, Gaurav, Pierre, and thank you for having us on your session. I'm just going to quickly introduce our team. Right by my side is Jennifer Snyder, who will be assisting me in the procedure. And at the top of the screen, we have Regina from anesthesiology, our nurse anesthetist, keeping my patient very comfortable. And we have a team of my partner, Dr. Subsparsh, who will be presenting the case. And then we have Rick Uter from Medtronic, who will be helping us with the PSA. And we have Michelle, Natella, Angela, Mark Akutsky, our anesthesia team here. And Jessica is at the Pruker, helping us analyze rhythm. Thank you for joining us. Faiz, can you present the case?
Of course. So I just wanted to talk a couple of minutes about the patient we have today. You can go to the next slide. We have an 80-year-old gentleman who came to us complaining of fatigue, dizziness, and he had recent episodes of syncope. He has a history of coronary artery disease, status post-CABG, a history of permanent atrial fibrillation, as well as hypertension. The medicines he was on were warfarin, aspirin, simvastatin, and metoprolol, which had recently been held due to his episodes of syncope. Next slide, please. This is his baseline EKG. You can see that his rhythm is atrial fibrillation. His QRS morphology is relatively normal with a controlled heart rate. Next slide, please. He had a Xyom patch monitor as an outpatient, which showed episodes of bradycardia and pauses, as you can see here, which were correlating to symptoms. Next slide, please. For these patients coming to the lab for conduction system pacing, we do get echocardiograms on the patients. Previous slide, please. And that is because, number one, we want to look at their valvular disease. If they have any evidence of moderate to severe atrial stenosis, and they're being planned for either TAVR or SAVR for AVR, we do want to maybe shy away from implanting a His bundle lead in that region because of the complications after the surgery that can occur. Also, we want to look at their septal thickness and the IVSD in helping to understand if we do decide to implant a left bundle lead, how thick their septum is and whether that can pose any challenges. Here you can see the apical forechamber as well as a peristernal long axis, and you can see he had a normal ejection fraction. His intraventricular septal dimension was about 1 centimeter. 0.8 to 1 centimeters were the dimensions. You can go to the next slide. The pacing protocol we have when patient comes to the lab for indication with RV pacing are they come to the lab, and if they have a normal QRS or no evidence of left bundle branch block or HV disease, that is HV block or prolonged HV interval, they move to the left pathway, which is His bundle pacing. Once we implant a His bundle lead and we find that the His bundle threshold is above 1.5 volts, we do move on to left septal pacing. If they do have evidence of HV block or they have other evidence of His Purkinje conduction system disease, like a left bundle or a right bundle, we do go to left bundle branch block pacing. If we are unsuccessful, we determine whether they need a CS pacing with biventricular pacing technology, or they get just a regular RV septal lead.
Right, thank you, Faiz. So we have access through the cephalic vein. I still use cephalic vein for access, so we're ready to proceed. I'm just going to show you the catheter we're going to use. We have the Medtronic C304 His sheath, and this has the ability to deflect the sheath, and I'm trying to show you the septal curve on the distal end, and so this makes it a lot easier for us to implant a His bundle facing lead. It takes the fun out of trying to map with the C315 His sheath, which is a little bit of a technically challenging for some people. All right, let's get started.
So for this patient, we're going to be bringing down the sheath here, and you'll be approaching the His bundle area for mapping.
So have you now moved to using the C304 His curve sheath for all of your implants?
No, not really. It's so for His bundle pacing, I think the C304 His is a excellent sheath. But for left bundle pacing, I'm struggling to figure out which is the better one. Sometimes the C315 works very well. Most of the time that works well. But C304 His is not very friendly for left bundle branch pacing because it's a stiffer sheath, so I try to use the C315 His first before I go on to do the left bundle branch pacing with the C304 His sheath. All right, so we can show us the fluoro images.
To clarify the point that you just made, Pugel, the C304 in your experience tends to bump the right bundle. I'm assuming that's why you're particularly careful with it in the setting of left bundle branch block.
Yeah, not only that, plus the sheath is stiffer. With the C315, it's easy to just rotate the sheath, advance the sheath across the valve into the ventricle without too much concern for it causing any perforation or anything like that. With the C304, because the sheath tip is a lot stiffer, you want to be very careful, move over a wire, or at least move over the lead before you get into the ventricle. All right, so we are, right now I've gotten across to the right atrium, and I'm going to leave the sheath there and get the, yes, go ahead.
Yeah, Pugel, great. Your obviously extensive experience here, and I'm just curious, your algorithm showed either His bundle pacing or left bundle area pacing. Is there any indication for anything other than that. So even if you're thinking the patient isn't going to be pacing over 40% of the time, or your data, I think even over 20% of the time, do you ever go to the RV septum or RV apex anymore?
No, that's only if we fail. And when we try lead-based implants, then I would say that right now we are at 98, 97% that we will get into at least left septal pacing, if not left bundle branch pacing. So RV apical pacing is a small number. And the other main patients would be micra leadless pacemaker who need a leadless pacemaker. So we don't use RV pacing is almost obsolete, at least in this lab.
That's great.
I guess
You know,
a good argument could be made that we should never go in the RV apex, since that's the most probable part of the RV that you might pace that you're also likely to perforate, particularly given the advent of all of these delivery systems that we now have access to that make it very simple to go on the septum.
Just to follow up on that point that was made earlier about micra, you know, proponents of micra would advocate for a septal position of micra in order to try to both have improved safety as well as, although not conduction system, capture a narrower QRS. For a patient like this who has AFib, would you ever consider something like a micra versus a conduction system device?
Yeah, in this patient, we chose the lead-based pacing because he's not on any beta blockers. Right now, his heart rate at rest is in the 30s to 40s. And his coronary disease, he needs to go back on his beta blocker. So I think his percentage of pacing will be more than 20%. So that's why in him we chose. So even in those patients whom we don't anticipate, unless we have a strong indication to do micra, the risk for infection or other reasons, we generally stay away from micra at this point. Hopefully, conduction system pacing micra will change that practice.
Yeah, that would be amazing.
So I just want to quickly show a unipolar connection setup that we have for his bundle pacing. So we're going to use the lead to map. And so I'm going to go to the fluoro now. And you can also simultaneously show us the PSA as well as the Pruka mappings. So I have my lead just right outside the tip of the catheter, as you can see on the fluoroscopy. And on the electrogram, we see small atrial signal and a slightly larger ventricular signal. That would suggest that we are near the annulus. And right now, it's all about moving my sheath a little bit by flexing the catheter to get higher up on the ventricle. One thing to remember is that the lead itself, so he's got significant AV nodal disease. So right being around, he develops significant slowing of rhythm.
So, a couple of questions for you. One is, do you ever put a backup temporary wire in if you're worried? Is there, based on QRS width and so on, in case you're going to get asystole during your manipulations? And B, I see you're doing this mainly in AP. If you've got any tips for the audience as to the best views to use if you're struggling with lead positioning, if you're not getting optimal signals.
So, yeah, you're right. So if your patient has underlying left bundle branch block or in AV block, then we would definitely have a backup lead. So I would have access. In this patient, is chronic atrial fibrillation. There was no lead for atrial lead placement. So we just have a single access. And because it's primarily AV nodal disease, that's what I presume at this point. Hopefully I'm not wrong. We didn't need a backup lead at this point. So I'm just going to move my lead around. Mm-hmm.
Can you please comment on the fluoroscopic view that you choose when you're doing these cases? Looks to me like at the moment you're AP, which is going to superimpose the atrial and ventricular planes on one another.
Yeah, so for his bundle pacing, we don't generally move our plane that much, and it's primarily AP view, but when we do left bundle, then we go on to RAO and LAO projections. I'm going to concentrate a little bit on trying to map, and Faiz, you can answer questions
Yes.
well.
Yeah, so maybe you guys, we can't take for granted that the audience is going to be familiar with all of the sheets that we potentially have access to. By any chance, do you guys have some C315 HIS sheets there that you could focus the camera on to
Yeah,
let
we
people
can.
know
We can.
Can you show us C315?
So
Yes, we'll get that set up.
I briefly had a glimpse of a HIS electrogram, so sometimes trying to find where the HIS is going to be is the first part of the procedure. Can we show the HIS electrogram that we saw?
It's notable and worth pointing out that working with this sheath, it is really quite common to encounter heart block as a consequence of how stiff the sheath is, and when you curve it up, it has a real tendency to whack into the AV node and into the right bundle branch. So it's very common to encounter this, sometimes a little bit nerve-wracking heart block at the time.
Yeah, you're right. In the sense that when the screw is sometimes very sticky, and when it gets attached to the tissue, and then you're trying to flex the sheath, and it can all of a sudden just jump out. So
yeah, actually, that's a super good point.
Tiny HIS there.
Can you?
I'm going to take a cine shot again. Say that again.
With your approach to mapping,
My audio is losing. I can't hear you.
so the question maybe
I lost the audio.
In your lab, do you begin with mapping the atrial side and then go ventricular, or do you begin ventricular and then pull back?
We start from atrial for a couple of reasons. So even not just mapping, but to fix the lead, if I cross the right bundle branch block and the threshold is not adequate, then I can still map and go distally. But if I start distally, that's always my concern. Whether will I get right bundle branch block that I can't correct afterwards. So here we have a tiny HIS signal. Can you go to 10,000 again? Okay.
Any tips on filtering for a HIS signal in atrial fibrillation? Because I certainly know when I'm doing AV node ablations, finding the HIS can be a bit of a challenge in AF.
Yeah. So in this case, I don't know. Unfortunately, today is not the best day in the lab with a lot of noise on my HIS signal. Normally, we have very clean signal. So there's a lot of 60 hertz noise on it, which we're not able to eliminate. But yeah, so in atrial fibrillation, sometimes you see a lot of HIS signals when it's not there early on. So you got to be careful and watch and look for those tiny potentials that's there. So we have a HIS signal. So the amplitude of the HIS signal is not the full determinant of what your final threshold is going to be. So I'm just going to gently fix this lead with 1 or 2 rotations and make sure that my HIS signal is still good before we make a final fixation or even initial assessment of threshold. So I was gently trying to push the lead and my signals got smaller, so I'm not going to fix it here. So I'm just going to pull the lead back a little bit, as you can see on the fluoro. Now the signal is a little better. I'm going to counterclock my sheath a little bit and hope that I can find that signal. Some patients have a large, full length of HIS signal. This one doesn't seem to have as much of a HIS signal as I would like to see.
And are there any patient characteristics, or if they have severe TR, is that something you're more concerned about when you go in for a HIS bundle?
That's a good point. So actually, I find that the HIS bundle pacing is easier in patient with TR than an RV lead placement. And post-procedural TR also is a lot less with HIS bundle pacing.
Do you measure the HV when you're looking to make sure you're not going to be pacing the right bundle as opposed to the true HIS? Or
yes,
do you just wait
we do.
and start?
No, we look for the HV interval has to be more than 35 before we fix it. Otherwise, you will cause a right bundle branch block.
This gentleman's HV interval is 50.
Yeah, but I'm saying when you're placing the lead itself, you know, as Pooja's pointing out there, that otherwise you'll end up pacing the right bundle when you screw it in.
Yes, you're right. We need to make sure that there's a bigger hiss there. Is that right? Yeah. It's a very tiny area, and I have to very carefully move the lead here to. So I have a stable hiss signal, so I'm going to make 1 or 2 rotations just to see if I can fix it here.
Spoogel, while you're doing that, it may be worthwhile to point out to the viewers at home that your routine setup uses Pruka with all 12 leads and a unipolar recording. When you were first starting out, were you using the programmer, or did you very quickly move to using Pruka?
No, so I was I would say that 5 to 6 years I was using primarily the PSA. And when I started moving to Pruka the 12 lead was always there. But to recording electrogram, that's only happened when I started publishing because that was the requirement, and I didn't have those. I had separate electrograms and 12 leads, but to put them all together in one, then it became a routine. And I saw a neat trick. These connections were not available. I didn't know of them. I visited one of the labs in New Mexico, and they showed us all the extra cables that you needed to connect. So you can simultaneously display in Pruka and in the PSA. So we have a small hiss signal. The R waves are, we can also show the Medtronic analyzer. The R waves are like 3.9 millivolts at this point. So it's not too bad. And I'm going to show you the fluoroscopic image. So the lead is barely outside the sheath. The hiss signals is not that optimal, but we're going to try to pace here and see what our threshold is. Doing a threshold before fully fixing the lead gives us an idea of what your final threshold may be at that region, because the sheath gives you good forward septal support. So go ahead, Rick.
Can we show the electrograms while he's pacing?
Yeah. Can we show the 12 lead, please? Yeah. So we have non-selective capture. What's it? 5 volts you're already missing. 10 volts you have his capture. 6. 6 has it. 5.
You're at a pulse width of 1 Poogle or 0.5?
We are at a pulse width of 1 millisecond. That's usually our starting point. So not happy with the hiss threshold at this point. So before I fix it, I'm going to look around to see can I get a better hiss signal. Sometimes if you can't find anything, then I do a fixation and see if I can get a better threshold. So I'm going to try to reposition this lead.
So what is the higher threshold that you would accept before saying, even if you went to multiple sites, before saying you want to do something else?
So pre-left bundle branch pacing, we were accepting thresholds of 2.5 at 1 millisecond. Now we want 1.5 volts to accept a hiss lead, otherwise we go to left bundle branch pacing.
So since we're watching a live case, I think people really, they're going to want to get as much of a feel for what you're doing as possible.
Okay.
Can you very clearly explain what clockwise rotation and counterclockwise rotation affords, differentiate that from the left and the right side, and also speak to the point you mentioned earlier, which I think is really important to appreciate, about how the lead can stick?
Okay. So if you can focus on my sheath. So one difference between C315 hiss and C304 hiss is that this, the way I'm holding the sheath, the direction of the deflection mechanism is at 9 o'clock, And that is the home view. That means the tip of the catheter and the septal position is, that's the home position of the catheter. So clock, I'm gently rotating. This is not a major clockwise rotation. I may do 5 to 10, 15 degrees clockwise towards 12 o'clock. And if I do counterclock, it'll be going downward. For his-bundle pacing, very rarely you have to do counterclockwise torque because the natural curve itself is pointing towards the septum. For left bundle branch pacing, we may have to do a lot of that. So here, generally clockwise rotation to get off the atrial annular to cross the valve, we may have to clock a little more and then let the sheath come back. Does that explain? Meanwhile, while I'm doing that, I think we have a slightly better his signal. And can you pace here, Rick, 5 volts? So we're not capturing his there. Okay, I didn't even fix it there, so I'm just going to off pacing. So this patient doesn't have. So you talked about being sticky. So the exposed screw often gets easy to attach. It's a good thing as well as sometimes it could be a pain, as Dan was pointing out. Because when you didn't know that it was fixed and you try to deflect the sheath, then it can jump. So I'm gently clocking the sheath to try to cross the annulus here. That I cross, then I get a lot of PVCs. I'm just going to come back. So I found that when I went higher up on the septum, I wasn't finding his signal, so that's why I'm mapping slightly lower on the annulus. That's where I was seeing the his signal.
So to clarify, the point you were making is when you clock the sheath from the left side, you're driving the sheath more anteriorly and towards the ventricular plane. When you're counterclockwise torquing the sheath, it drives the tip more posteriorly and superiorly towards the atrium.
Correct.
That fair?
Absolutely right. Yeah. Yep.
And then the issue
so we
with
have a better his signal. Yeah, go ahead.
The reason I want you to focus on the stickiness of the lead is those cases where the lead can become entrapped. I was wondering if you could, because you actually have an interesting experience looking at the University of Minnesota living heart model, showing how you can wind up with sort of an entrapment of the lead tip.
Yeah, so what Dan is pointing out is that the atrial and even the annular surface of the heart has a lattice-like fibrous tissue arrangement there. So the lead can stick onto that fibrous part, and when you pull, it pulls the whole thing. If I can show you if you think of this as the surface, and it can pull the whole thing, and you clock or counterclock, it just pulls up and makes a long string of the tissue. And that's what sometimes gets entrapped. Even without fixing the lead, you can see it. And so in the beginning, we used to be very worried, what is this? And am I pulling a valve leaflet or something? It turned out that this was all fibrous tissue. We could see it in cadaver models, what it does. And so, at least I don't want to say this to everybody, but I'm not as afraid to pull the lead back into the sheath and hold it for a few seconds before it just comes off. So it can be a harrowing experience in the beginning when you didn't know this. It was until we saw the models in the lab. So we have a better his signal. Can you do a quick threshold before I fix this? Okay, 5 volts. Okay, 3 we are losing. So I'm going to, for lack of better sight, I'm going to fix this lead and see if I can get a good threshold. If I cannot get good threshold, then we're going to go on to left bundle branch pacing. Okay.
So, Pugel, can you clarify what you just saw there?
Yeah. So what we had was, can we go into the review screen? So we have the screen correctly. That's that's okay. So you have the review screen on both. So in that page, the first paced rhythm is actually non-selective his funnel pacing. That's around, was it at 3 volts that you lost? Yeah. So the next beat is only right ventricular capture. So we need, when we know that that is transition from non-selective His-Bundle pacing to right ventricular pacing. So we want that. We are focusing mainly on what the His threshold is going to be. And if it's non-selective, the RV will be our backup from the same lead. It may not be important in this patient, but in patients with HV disease, pre-left bundle branch pacing, that was our primary important aspect, that we have to have a good RV capture threshold, and it has to be non-selective before we accept in HV disease patient. So if we can focus on lead fixation, so once the lead is partially fixed, the sheath doesn't have to be supported much. And so I'm going to hold my sheath with my left hand gently, and then I'm going to rotate 3 to 5 with my, between each rotation, I'm pinching the lead so it doesn't torque back. And when I finish the rotation, it generally will torque back, suggesting I have adequate fixation. So I got the lead rotate back twice. I may provide a little more, one more, to see a better, brisker return on the lead. Yeah, I have that. So I'm going to connect now. Let's see what His electrogram looks like. Okay. Can we go to the next page on the... I did about 4 to 5 turns.
Can you comment
So
how
you
often
initially
see
started
it
with 1 or 2
markedly?
and gave it a...
Oh, I'm sorry.
Yes,
Yeah,
you're
it's
right.
hard when we don't see each other. How often can you comment on how often, when you completely fix it, it improves to where you just tested it? Is that infrequent, or often you'll see much more of an improvement now that you're fully fixed?
It's a hit or miss sometimes. I would say that it's a 50%. What I was looking for, can you go back to the first page, please? So when I fix the lead 1 or 2 turns, and I would normally like to see a little bit of injury current on the His electrogram, which we didn't have at all in this case. And even after fixing now, I don't have injury current on the His bundle. I have a lot of right ventricular injury current. Can you go back to the next page? So you can see the His M, it's for lack of better number, we just left it as His middle. But that is basically a high-pass filter is changed from 30 hertz to 0.5 hertz. So that's when you can demonstrate injury current. Can you change the gain down to 2500 on the His middle? So now you can see the RV injury current, but the His injury current is hard to see. The His signal itself is not that big, but usually all this pointed to me that in this patient so far, the His is somewhat deeper structure. So my His threshold, I don't expect it to be that much better in this case right now. So let's check threshold. Can you go back to the first page? Yeah. Okay, that's 5 volts, 4 volts, 3. Okay, keep going down.
Okay, no, I was just going to ask if you are struggling here, is it worth
Go back to
looking
5.
with the other sheath, the 315 sheath, before going to left bundle pacing? Whether you find that can sometimes help you, just because of the slightly different angulation.
No, I think this case, we were able to find the His signal multiple times, and I never saw anything large, anything to suggest that it's. You may find a better spot without with a regular C315 His sheath. And after fixation, actually the threshold is worse. I don't think we have His capture. Can you go to 10 volts? See, now so this is where we can be fooled. So 10 volts, this is definitely His capture. And you can see the rapidity of activation. Unfortunately, the Pruka has a lot of noise with the unipolar pacing. But you can see rapid activation there. But at 5 volts, it looks like it has His capture, but the slew rate for lead 2, 3, V4, V5, V6 is all pretty long. And you can actually use STIM to peak LV activation time. Can we measure to V6.
Can you please show the review screen on the Pruka?
Yeah, it's about 108 milliseconds. So usually it's in the range of 90 milliseconds or less for hispanal pacing. So there it is, 91. And so you can be fooled thinking I have hispanal capture, but this is all parahissian RV capture. And Dan can expand on it. I know he hates the word parahissian to describe hispanal capture, except in this situation where we're talking about accessory pathway.
I just hate using it for his bundle capture, but it's perfectly great for saying parahissian ventricular capture, which is what you're demonstrating.
Yep. So this threshold is no good. I have to reposition. I may make one more attempt to find a his. If not, before we do that, can I have a RIO view? I'm going to take a fluoro reference shot of my his location.
Mm-hmm. Something you did quite naturally, Pugel, which may not be clear to everybody, is that you checked for voltage-dependent changes, even in the setting of a QRS, which on first blush looked okay. Is there a cutoff with which you would say, you have to see a change? Do you go straight to 10, and if you don't notice a difference, you know that you're dealing most likely with a septal location as opposed to a conduction system location?
Yeah, so in hispanal pacing, it's a lot easier to confirm that you have conduction system capture because the QRS morphology changes are well described and you can assess it. Where it becomes a challenge is when you have bundle branch block, bundle branch correction and no correction or partial correction, it becomes a little bit of a challenge too. So there I want to do that output dependent threshold changes to see. I have a slightly better his electrogram by moving the sheath a little bit, so I'm going to try to fix it one more time here, and assuming I have a... I don't have...
In these down moments, there's a couple of questions from the audience. One person's wondering if anybody's using 3D mapping systems on a regular basis, and they go on to point out that it's very elegant and reduces fluoro. Any comments on that, Pugel, or any of the other folks?
So I'm just going to do a fixation. Faiz, if you want to answer that.
It is an option, but I think for most cases, fluoroscopy, the lack of fluoroscopy, using 3D mapping and what you lose in what you can get from fluoroscopy, it might be the risk isn't worth the benefit from our experience.
So I found a slightly bigger his signal, so I'm going to fix the lead one more time and hope this time is better. But I still think this is a place where a 2.5 millimeter screw might help us better numbers, because we know the his is there. We know we can capture it, but it's requiring higher output. So.
And Pugel, can you comment a little bit on operator experience? Do you think you obviously have more experience than probably anyone in the world, I suspect, or close to that? Can you comment on training of fellows, training, or getting appropriate experience to get to places where you're reducing your procedure time and getting better thresholds? How many does it take?
So I think the European group and Sunit Mittal and others have published their experience on, I've forgotten the early struggles, but it takes about 25 to 40 cases, it looks like, for people to get good at hispanal pacing. The left bundle branch pacing seems to have a shorter timeline for the number of cases to get good at least to understand. So we have a better his signal here, and our waves are 8 millivolts. And can you go to the next page just to see if there is any his injury current, and make that one as 10,000 gain on the his mid?
Can you show the electrograms?
Shows signals, yeah. I have to say you're getting
move it
beautiful
higher.
interface action potentials on your catheter. Injury.
Yes. So I'm not seeing, when the ventricular signal is big, it becomes harder to see his bundle injury current. But I don't think I have his bundle injury current here. The reason I'm harping on his bundle injury current is that we see it a lot more with deflectable sheath because it gives much better support. Acutely, his threshold can be high, but when you clearly have injury current, that threshold will become sub 1 by the end of the case, almost all the time. So that's why we're paying more attention to the injury current on the his bundle. So I don't think we have. Can you go to 5,000 gain on? Yes. Sometimes that may take the ventriculus. So I don't think we have his bundle injury current as clearly here. So let's do a threshold test here. So now we are bipolar. So we have clear his capture at 5 volts. Okay. 4 volts. Oh, it changed already to RV. So I'm not happy. I think I'm going to, in the interest of time, I'm just going to go on to left bundle branch pacing here. Because I think this is one of those cases where the hiss is somewhat deeper. And I mapped briefly on the ventricular side. I couldn't find any hiss signal as we were talking earlier. So I don't want to waste time. Just go find the hiss on the left bundle branch pacing at this point. Can we put the reference screen on the other side? Any comments from the panel? Any suggestion, Dan, that you would do differently at this point?
No. I guess you could, just for this, I'll be a sort of a His bundle heretic for a moment, a role I'm not comfortable playing. But you can make the argument, I suppose one might, that the septal pacing QRS that you got previously with non-selective threshold that was too high, but parahiscine ventricular capture that was adequate, would it be reasonable to leave the lead in that position and call it a day?
Would not be unreasonable, depending on the indication. If you think he's going to get paced higher, I am kind of, I should say, obsessed in making sure, or perfectionist, if you want to call it. I don't know which is the right word. But I strive to get conduction system capture as much as I can.
So a critic would say, well, perfection is the enemy of the good.
Yeah, you're right. But it all depends on what challenges I have, and I don't. If I think I'm getting into trouble, then I stop.
Yeah.
So this is...
What do you flush with?
What do you flush with was the question?
Yeah, what do you use for flushing your sheets?
Heparinized saline.
Yeah. You want to expound on that a bit?
Yeah, with heparinized saline, it just makes keeps things slippery. Anytime there's blood on the lead, especially in this position where Pugel's going into the septum, when you turn the lead and try to deploy it, the blood on the lead makes things very sticky and it's difficult to actually twist in your hand. So keeping your gloves as well as the back of the lead clean of blood are essential for success at this point. You can see here that he's moved into the RV septum.
If you're not accustomed to placing leads via a sheath delivery system, the sheath can easily get clotted and coagulated. So it's very helpful to use heparinized saline to flush the sheath to keep it clean so that the lead doesn't get gloved up inside the sheath.
Can you paste, Rick?
Just comment on anticoagulation in the patient with atrial fibrillation. Are you doing the same thing as you would with any transvenous lead, or keeping them on anticoagulation or not before the procedure?
Yes, this patient is on warfarin. For these cases, we keep them on continuous anticoagulation.
His INR is 2.7 today. So I found a site about 2 centimeters distal to his location. We have a nice cable that's running along the direction where we need to implant the lead. So My nurses knew where I was going to go, so they placed it exactly where it should be. So you can see that.
Do you want to take us through the positioning for left bundle pacing, what you're aiming for?
Can you point out to them?
We took a fluoroscopic shot. If you can show the review screen on fluoroscopy.
So again, we noticed you're doing this in AP Pugel. Is that what you usually do for left bundle as well?
So for this portion, he's actually moved to RAO 30. So we usually take a shot of the His bundle catheter, the His bundle position in RAO 30, and we have that on the review X-ray screen. I don't know if it's able to project, but once we take that shot, we draw an imaginary line to the apex of the heart, and we move maybe 1 to 2 centimeters down from where the His is.
The C304 His sheath is hurting me here. It doesn't give me the angle to get into the ventricle the way I would like to go, because the heart is also somewhat vertical. I may try for a minute, and then I find that I might have to go to the C315 His sheath because it's a very narrow angle. I can't see the way it's pointing towards the septum here. And I don't have enough of the support to fix the lead. So, okay, there it is. I have a better support now. Okay, so if you can focus here. So I'm having a counterclockwise torque on my sheath. As you can see, it's pointing at 6 o'clock. And I'm holding the sheath in place with one hand, and I'm going to rapidly try to turn the lead. The idea is to go as fast as possible. And Rick, you're going to watch for right bundle branch PVCs if I happen to be successful getting in. There, okay.
So you can see PVCs on the...
You saw that I only turned the lead 3-4 times. Can you show us the review screen where the right bundle branch block PVCs are seen? And so that is a sign that you've crossed the septum into the LV side. Usually with the first 2 beats I should stop, otherwise I may perforate. So so you saw that it wasn't too many turns in this patient once the sheath is in the right angle. And can you replay the fluoro shot that we are doing? And you can watch that the sheath, 2 things important. The sheath is stable, it's not getting pushed back, and then the lead is moving forward as I'm rotating. It crossed that cable just to show that we went across. I don't have a potential, but let's pace here to assess the left bundle branch pacing characteristics.
Would it be possible to see the LAO view to look at the angulation of the lead in that position?
We are going to go LAO, please. Yep, we'll go LAO. So you can see what is the stim to peak LV activation time at 5 volts. 25, 30. 74. Okay. Come down on output.
Post the question.
Move the table towards us. So slow. Okay.
Right.
So this is the fluoro view.
Yeah.
This is
what is the stim to peak at 1 volt?
Mm.
So we have both at high output and low output. We have stim to peak LV activation of about 75. It looks a little bit, at the lower output, it looks wider. Can you go to 0.5 that you had?
Can we see the signals? Yeah.
Yeah.
Okay, go to 0.5. Okay, what is the stim to peak here?
Can you show the review screen?
Still the same, huh? 74, okay. All right. I'm going to inject a little bit dyes to show how deep we have gone in. So I don't have a clear demonstration. Yeah, go ahead. So
how much counterclockwise torque did you have on the sheath when you were screwing in?
So I went from 9 o'clock on the hub to 6 o'clock. So it was almost, 90-degree turn on the 360 clock.
Yep. All right, I think,
so with this sheath, you don't have to turn so much as your C315 His sheath.
Right.
So we have just gone exactly 10 millimeters in. so you can see the fluoroscopy view.
Now, the button is right in the way of your tip, but what are you going to do? Can you...
Yeah. We can move if you want.
That'd be great. Yeah, it's a little hard to see from one's computer, I think.
Okay, is that better? So I have still dye in the sheath. I'm going to inject the saline now, so you'll still get another picture of that, so you can see. So at this point, I don't see a non-selective to selective or non-selective to LV septal capture. And I don't see a potential, or maybe I have a tiny potential. Go AP, please. So let me do bipolar. Sometimes that makes it harder to. So before I do that, can you pace at 10 volts? So one thing is to see, do I have to go in further, is to see if the stim to peak LV activation gets shorter at the higher output. So can you update and measure stim to peak LV activation time? So that looks like a little short. I'll come back a little bit on. So that's V71 still, not too much. Can you go to 1 volt? That looks wider visually. Yeah, so I'm going to make one more turn. Hope I don't. What is the impedance? So we still have a lot of injury current off pacing on the ventricular electrogram, and the impedance is high, so I know I'm not close to perforation. So I'm going to give one turn here.
So Pugal, one thing you did extremely effortlessly was getting it perfectly orthogonal in actually the RAO view. You didn't even look LAO. Were there any clues that you had in the RAO view that you were well opposed to the septum?
In RAO, in this patient, it was a little hard, but I would like in a C315 his sheath, I want the sheath tip, the distal 1 centimeter, to be pointing between 12 to 1 o'clock location. In a vertical heart, that is challenging. I don't have such a clear idea what to tell with the C304 his sheath, because that distal tip angulation is different for C304 his. It doesn't have the third curve that is present in the C315 his sheath. So it was just more by the feel and the how the lead was penetrating. So before you were watching, I did do one attempt to advance the lead, and I got nowhere. So I reoriented my sheath based on what I learned from that, and I made more counterclockwise torque. So it was a trial and error sometimes in these, how much to turn to keep it perpendicular. Can we pace here? Okay, okay. 1 volt. Okay. So I'm not going to venture any further here. We're going to check bipolar threshold because we can look for anodal capture here. So I'm just going to advance my lead a little forward, pull the sheath back, and so see what the anodal threshold is here. Because the lead was barely touching the, what was the unipolar impedance?
740.
740. So, all right, let's do now. Okay.
Can you just quickly comment how you use impedance monitoring?
Okay, so you can do the numbers while I talk here and figure out what the anodal. So what we're looking is, as you advance the lead deep, the impedance goes up to 700, 800. If it goes beyond 1,000, you're generally not going perpendicularly. You're going tangentially along the septal wall. So as you get closer to the LV endocardial surface, the impedance starts dropping. We don't want to see more than 200 ohms drop. And as I'm seeing an impedance drop, I'm also looking at the ventricular myocardial injury current. If you still have myocardial injury current, then you're still intraseptal, not intracavitary. So that's kind of what if I impedance drop to, normally it would be around 500 unipolar impedance at the LV septal surface. Occasionally you can see 400, but anything less than 500, I'm a little nervous and cautious at that point. Did you see anodal capture? So go to 10 volt. So no, we don't have anodal capture because I think the ring is not in good contact, which is not critical in these patients. So what's our pace QRS duration? Say that again. We have a QRS duration of 118 milliseconds from stimulus to end of the QRS. I think we are as good as we're going to get, and we're going to accept this position.
And can you comment on your R wave amplitudes? Did you see that change at all as you were going, screwing it in from before or after? Any?
Yeah, so you find all kinds of changes. So as you start the R waves, maybe I would like to have it more than 5 on the RV septal surface. As you go intramyocardial, it may increase to 10, 20. And as you reach the LV septal surface, it can start decreasing. And again, we want it to be above 5 volts there. And once you connect bipolar, if the ring is in contact, then the overall ventricular signal can become even bigger at that point. In this case, the R waves are only 4 millivolts. Let me see what the unipolar is. That was bipolar signal, didn't help too much. Unipolar is also 4.2.
So Poogle, I'm going to have to interrupt. We're coming to the end of the session. I want to share with you the poll result. The question that had been posted was a 75-year-old patient, ischemic with EF of 42%, who's going to be requiring a lot of pacing, and what is the ideal pacing option? It looks like we convinced only 58% of the audience that it should be His bundle pacing. I think that also harkens to a point I wanted to raise, which is that a prior talk in this conference was His bundle pacing versus resynchronization. Next year, when the conference has the same talk, it should be called resynchronization versus pseudo-resynchronization. And with that, I think I want to just point to the fact that this was a great case to share because it shows you the steps that you can go through to ultimately achieve a result of conduction system pacing by hook or by crook using techniques that are certainly within the standard or somewhat higher than standard toolbox of most implanting electrophysiologists. But clearly this does require a little bit of more expertise and more electrophysiology than standard pacing. But I think what you are getting in return for that is you're causing less harm to the patient if they require a high percentage of pacing, and it's well worth the extra expertise and time, in my opinion, to try to achieve this for most of your patients. Does anybody want to make any last points?
Since you have a couple of minutes, can I do one last? So one little thing I want to emphasize is when you slit the sheath for the C304 His, it is important that you undeflect the sheath completely. Otherwise, the cable will get stuck in the middle. So as you slit the sheath, you want to no more deflection on the sheath to be able to. So then it comes out easily for the slitting. If you had it deflected, then the cable gets stuck. And so that's the final fluoro position. We're going to keep that a little bit less of a slack, and that's going to be all we're going to take. And we're going to accept this lead position and move on at this point. Thank you very much for having us here, and I want to thank my team and for having this successful procedure.
Yeah, thank you very much. Nice to see you all.
Excellent.
Great case.
Bye-bye.
All right.
We have 2 minutes to wrap up. So I wonder if maybe each of you can make a quick 50-second comment about any thoughts you have about the case and recommendations regarding His bundle pacing. Putting you on the spot.
Well, I mean, we've mainly been focusing on it in patients with PR prolongation, right bundle branch block, and a degree of LV impairment, because obviously those patients can potentially benefit better than just individuals with normal LV function. I think the key learning point here is to have the flexibility to go between his bundle and left bundle pacing, because in the end he got an excellent result with this procedure, but you do need certainly some patience and experience to do this well. It's quite obvious.
Great. Andrea?
And, we've been, the one group of patients actually we haven't done very often except for failed CRT. So if they have clear indications for bivalve pacing, I guess we're not as experienced, certainly as Pugel in his center is. So for those patients, we haven't been going up front except for maybe considering the right bundle patient, but the ones who have classic left bundle and CRT indications, just because of the vast data in that area. But I think this was a great case. I think, it shows obviously incredible flexibility to go from one to the other. And I think a really great illustration. Thank you.
Right. Yeah. Thank you. Gaurav, any comments? Parting shots?
Yeah. Well, I would just say that, Pugel is a true master at this. And one thing for the observers at home to note is that it's very subtle in terms of the hand manipulation when performing his bundle pacing. Very small moves can make a big difference. And then to have a systematic approach looking for output-dependent changes and then moving to a septal location in a way, again, to look for those changes. I would point out in this case, we don't have confirmation that we have left conduction system capture that we sometimes see with the presence of a left bundle potential. But I think certainly for this patient, this position is associated with a terrific looking electrical resynchronization. And to echo what Andrea had brought up, we need to continue to acquire data, particularly data looking at hard clinical outcomes, which can really prove that this sort of electrical resynchronization translates into long-term clinical benefits.
For sure. That's great. Well, thank you all very much for joining me, and really appreciative of Pugel and of Richard Schilling and his colleagues for putting this all together. So thanks very much.